One of the issues is about when I was in Boston, I did some of my research on neuroregulin cell signaling, which is related to, which acts on ERB receptors, so it's sort of this was way back in 95-97, and this is related to trastuzumab or Herceptin, which is used in breast cancer. So in about 2011, I started the cardio-oncology clinic at our medical center, and as you'll see, that more and more cancer survivors are surviving cancer, and they're getting what I call collateral damage with chemotherapy and radiation, and are now getting cardiac disease, and they're succumbing to cardiac disease. And as frontline physicians, you all will see more and more patients surviving their cancers. In fact, if you look at President Jimmy Carter at the age of 92, developed malignant melanoma to the brain last September, and I thought he was done. And then in December, they said he's completely cured. And you know, the last 20-25 years has been the golden age of cardiology. I remember when I was in medical school, we used to use, for acute MI, bedside commode and a laxative and an ICU stay of 5 days. And now we do all these things like ECMO, and we go all the way. And so I think the next few years as practicing physicians, you may want to keep your eyes out on oncology. More and more people will survive. So very briefly, given the constraints of time, this is a figure from Dan Lenihan's chapter in the Atlas, which I edit for McGraw-Hill. And the impact of chemotherapy or related to cardiotoxicity in cancer includes metabolic, electrical, pump, structural, and vascular. And so you get the whole gamut of patients. The typical patient I see in clinic are people who are receiving chemotherapy for cardiotoxicity. So they are started on chemotherapy, and the way it works in the US is the cancer pharmacist automatically orders surveillance echoes depending on protocol. It's protocol driven, the echo is read. As soon as there is a drop in EF or the patient is symptomatic, they send the patients to my clinic. And in fact, when I started the clinic, I was the only cardiologist doing it. This year we hired 4 more cardiologists just to do cardio-oncology, that is, manage patients with issues with the heart in the setting of cancer. And so as far as LV dysfunction is concerned, when they send patients to me, their biggest concern is they have to stop cardiotoxic chemotherapy because the ejection fraction has decreased typically by 10 points. So it's not necessarily it has to go below 50. If they're 65 and then they go down by 10 points, that's a significant impact, and that may trigger a visit to my clinic. The thing about cardio-oncology, unlike heart failure, there is a lot of data in heart failure. You know, all the studies studied 3,000 patients at least to show impact. But in as far as chemotherapy-induced cardiotoxicity, the sample sizes have been 100. So at best, so really it's still very empirical and it's still practice-driven. And I think realistically, registry-driven setups will improve, will give us more light on this. So if they are sent to me, I stop the cardiotoxic therapy. I typically start them on beta blockers to improve the ejection fraction. And once the ejection fraction, in 40% the ejection fraction will improve with exercise and medication. 40% the ejection fraction remains the same, and in 20% it gets worse. And in my experience, the people whose ejection fraction improves are the ones who take their medications regularly, who exercise regularly, and in their lifestyle they stick to a low sodium diet. The ones who get worse are say, I got cancer, I don't care, so they continue to drink and smoke, and they're the ones we struggle to improve their ejection fraction. And in some ways one would argue it's no different from garden variety non-ischemic dilated cardiomyopathy. In fact, the way to look at chemotherapy-induced cardiomyopathy is like it's a chemical myocarditis. And we know the natural history of myocarditis is very variable, and similarly here it's very variable. So once the ejection fraction improves, then that's a conversation we have with our patients, that it's shared decision making whether to continue the chemo or to stop it. And very often most often the patients want to survive their cancer, so they may roll the dice and we may re-challenge them in the setting of beta blocker therapy and ACE inhibitors and spironolactone, whether to re-challenge the cardiotoxic chemotherapy, and knowing fully well that the chances are higher. And the ones who typically who succumb to cardiotoxicity are the ones who have a family history of heart disease or hypertension, dyslipidemia. So the traditional cardiovascular risk factors predisposes them to cardiotoxic chemotherapy. And once their ejection fraction improves, then we re-challenge them if the patient is open to doing so with cardiotoxic chemotherapy, and continue the surveillance protocol. And typically once they're that case, I recommend to them to have surveillance echoes every 6 weeks while they're getting the chemo, because they get a combination of adriamycin, a cisplatin regimen, Taxol, and Herceptin. And the cancers which I typically see, I find are the ones which are anthracycline-based therapies, that is breast, small cell cancer, bladder, esophageal leukemias, Hodgkin lymphomas, sarcomas. I even monitor patients who received chemotherapy when they're 12, for example, for Ewing's sarcoma when they were 12 years old, and they come for follow-up to my clinic every year, and I was following this 30-year patient for the last 8 years, once a year, doing surveillance echoes, and I was saying, am I wasting his and my time by seeing him, And guess what? In the last visit, 6 weeks ago, even though he's very active, his ejection fraction had fallen by 20 points since the last annual visit. Just tells you that the surveillance has to continue lifelong. The natural history of these patients is very variable. And it's very difficult to get the buy-in from the patients if they are asymptomatic. But anyhow, this patient was glad that we continued to do surveillance, and he was only on one medication for management of heart failure, and then we started the whole gamut of medications to improve his ejection fraction. Clinical heart failure may ensue in about 5% of high-risk patients. And I've found that if for more than 5 years, we even have patients who we have actually transplanted them once they have had very progressive heart failure. And as I said, pediatric populations receiving anthracycline therapy remain very elevated. And part of it is when anthracyclines were used 20 years ago, no one quite understood the dose dependency, and they went and gave them high doses. Now we know that high dose anthracyclines are best avoided or at least minimized. Having said that, a lot of the sarcoma patients, the sarcoma oncologists tend to use heavy dose anthracyclines, because this is what the patient has to decide, whether he or she will succumb from sarcoma in the next 1 year, or whether they'll worry about heart failure down the road. And in fact, I've seen 7 cases of trabectedin cardiomyopathies, and trabectedin is a new drug which has been approved for sarcoma, and they are also based in the background of adriamycin. So adriamycin seems to hover around there. I think as more and more cancer regimens don't use adriamycin, for example immunotherapy, there was one study which came out from Europe where they used immunotherapy for breast cancer. Hopefully we'll see less and less cardiotoxicity due to chemotherapy. And the main mechanism seems to be inhibition of topoisomerase 2 beta. It's interesting, the cancer doctors are trying to kill the cell, they're trying to cause apoptosis, and the collateral damage is apoptosis to the cardiomyocytes and cause heart failure. And we heart failure docs are trying to save the cells. So the push and pull is in opposite directions. So you can see why there's a little bit of tension there managing these patients. So the risk markers for cardiotoxicity include age, kidney disease, concomitant exposure to radiation, trastuzumab, high blood pressure, female gender, and cumulative dose. So when it comes to combination therapy with trastuzumab and adriamycin, the studies have found that if you delay starting therapy with trastuzumab, then there's less of a damage to the heart. When patients are referred to me to see chemotherapy-induced cardiomyopathy, I try to see them within the week, because the sooner you can get to them, the sooner you can salvage them. And sometimes my schedulers don't know that. They say, "Oh, Dr. Baliga is booked out till October or till December." They won't do it. So I actually give the oncologist to contact me directly so that I can see these patients and add on and initiate guideline-mediated therapy immediately. The other options to minimize toxicity is liposomal and encapsulated doxorubicin is associated with lower rates of heart failure. But in the US, it's been restricted to the use of ovarian cancer, AIDS-related Kaposi's, and multiple myeloma. So we'll continue to see adriamycin-induced cardiotoxicity because this medication has not been approved. Dexamethasone was very promising but fell out of favor because it dampened the antimitochondrial activity of anthracycline, and there was a signal that it may be associated with increased secondary malignancies in survivors of childhood leukemia and lymphoma. I haven't seen many patients in our center using dexamethasone. And the therapies I mentioned to you are ACE inhibitors, ARBs, beta blockers. However, there is no robust data to recommend specific regimen. Ongoing studies include ICOS-1, PROACT, cardiac care. Again, all these studies are small sample sizes, unlike the big heart failure trials, which use thousands and thousands of patients. I think given that the bell is rung, I'm going to stop here, and thank you.